Dr. Salam, thank you for the invitation. I'm going to go ahead and share my screen. This is a pretty vast topic, so we'll try to get through as much as we can. Please feel free to, put your questions in the chat, but I'm happy to also share my email in the end if we're not able to get through to the questions. Give me 1 second, I'll go ahead. Are you able to see my screen?
Yes, it is
Yes,
visible.
we can.
Okay, perfect. All right, great. Okay, so my topic today is on women and epilepsy, and Dr. Alluded to earlier. This is a very important and relevant topic, and it's actually a very complicated topic. And to be honest, anything you could pick each one of these topics and turn it into a presentation, a grand rounds in itself, because that's how the literature pertaining to this is continuously evolving, and it's pretty enormous, and I think it's important for everybody to sort of be appraised to the topics. Okay, so let's move on. All right, so there's important neurophysiological effects that take place during different stages of a woman's life, right? Like from adolescence to pregnancy to menopause to postmenopause. And at every stage, we know that hormones sort of influence brain function from gestation throughout life. And seizure patterns also change at certain life stages, perhaps as a result of alteration of in hormonal changes. There's generally a complex bidirectional interaction between sex hormones and epilepsy. Hormones affect seizures, seizures affect hormones, and thereby disturbing, reproductive endocrine functions that affect ovulation, fertility, and sometimes also impacting menopause, early menopause, etc. Hormones can either promote epileptogenesis or slow down epileptogenesis depending on which hormone is involved. The two main ones that we typically talk about are estrogen and progesterones that change during the course of a woman's lifetime. And there's robust research in both human and animal models that support the following basic concepts. One is that estrogen leads to an increased seizures by downregulating the GABA receptors and acts as an NMDA agonist, which we know is all sort of like, seizure hyperexcitability. And progesterone does the opposite. It sort of tends to reduce the seizures and upregulates the GABA and works as an NMDA antagonist and thereby reduces, is thought to be anti-epileptogenic. I'm sorry, my screen is, okay, there we go. So women with epilepsy will face unique challenges due to the effects of seizures and hormonal functions, potentially affecting both sexual and reproductive health. A lot of the problems that women encounter can vary from like decreased libido, there's infertility, there's early menopause, PCOS. They're more common in patients with epilepsy than with general population. So we'll try to get through as much as we can with some of these topics. All right, so starting with menstrual cycle, I think this is the most common question that's comes up, like the definition of what is catamenial epilepsy and what it is and how you treat them. So in a majority of women and also men with epilepsy, seizures tend to cluster. Catamenial epilepsy is when you have women experience seizure patterns at the times of these hormonal fluctuations. It's estimated that 1/3 of women in epilepsy tend to suffer from catamenial epilepsy compared to 1/7 of the general population. There's a lot of theories that have been proposed, and there's existence of three different patterns of epilepsy, which we'll look at in the next slide. And generally speaking, 30 to 40% of women will have one of these patterns. And the treatment depends on whether a woman has regular or irregular menstrual periods. So, I alluded to that there's three different patterns that have been described as part of being catamenial epilepsy. An average periodic cycle, in a woman is about 28 days. That starts on the first day of the cycle. As you can see here, O is the ovulation period that takes place on day 14, and is preceded by the follicular phase, which is day 1 to 13, where the brain releases the hormones to stimulate the production of follicles, and usually one follicle will then go on to mature into an egg. Then the luteal phase is when there is release of progesterone happening, which is from day 14 to like day 20 something. And during the typical 28-day menstrual cycle, there's a lot of variations in estrogen and progesterone levels. So the C1 phase, that's called the perimenstrual phase, is arbitrarily assigned to happen between like 3 days before and 3 days after the cycle, with the first day being the day of the menstrual flow. So which is typically here anywhere between it's technically in the luteal phase, so it's just before menstruation. And as you can see here, there's a steep decline in progesterone. The red line is progesterone. So in the premenstrual or the perimenstrual or the C1 phase, you have a very steep decline in progesterone, and this is thought to aggravate seizures in this part of the cycle. And this level actually starts dropping about a week before the menstruation, but in the last 2 days of the cycle, there is a massive drop. And then we move on to what is called the C2 phase, which is the pre-ovulatory pattern. And as you can see here, the estrogen levels, the blue line is pretty high compared to the levels of progesterone. So it's when you see this relatively high level of estrogen that seizure activity is most likely to happen. And then the C1 phase, I'm sorry, the C3 phase, it typically happens in patients who have like anovulatory cycles, where progesterone it's not made after ovulation. And it starts again in the estradiol surge on day 10 and lasts up to 3 days after. So in general, majority of the women who experience catamenial epilepsy typically fall between the C1 or the C2 phases, and women who have irregular periods have like the C3 anovulatory trends or variations. This happens. Okay, there we go. Okay, so when we look at treatment for patients with catamenial epilepsy, the first line treatment is generally treating patients with conventional anti-seizure medications. So you just basically increase the dose of your medications around the time of your cycle. But there are other adjunctive therapies that have been studied and tried. For example, you have intermittent dose use of benzodiazepine around the time of the periods. The one that's formally studied it's clobazam, or it's otherwise called Onfi, where you dose it between 20 to 30 milligrams per day, 2 to 4 days prior, has been known to slow the reduction in seizures compared to placebo. Diamox or acetazolamide is less well studied. It's used it's been used for several years. I still have patients who show up on Diamox. But they've known to rapidly develop tolerance. But then the older studies have talked about some sort of efficacy between using between 250 to 500 milligrams of Diamox 3 to 7 days prior to the cycle. And then, how we talked about in the C1 phase, where there's a steep decrease in the progesterone just before, the period start. And therefore, progesterone supplements used in this half of the cycle, the second half of the cycle, has been studied for the treatment of catamenial epilepsy. The one study that I've pointed out, actually, there's two studies that pointed out there. What they did was they randomized patients, around 200 patients, randomized to 2:1, like progesterone, and to a placebo. The broad takeaway, the broad consensus from the studies showed that there was no overall benefit of natural progesterone compared to placebo for catamenial epilepsy. But when they did a specified, like a subset analysis, they actually saw that progesterone was somewhat effective in patients who had this perimenstrual or the C1 pattern of seizure exacerbation, and had about 50% of responders correlated with a reduction in seizures with the use of progesterone supplements. So we do have synthetic progesterones. This is administered every 10 to 12 weeks intramuscular, and it stops out of the regular cycle. And in patients with catamenial epilepsy, this is known to reduce seizure frequency by about 40% at 1 year. But it does, obviously, with everything else, you need to counsel about risks and, side effects and adverse effects. With the use of like long-term use of progesterone, there's always a risk of osteoporosis, the slow return to normal fertility. So when you're having this discussion with patients, you're counseling in terms of like, waiting out to see if like the risk outweigh the benefits. And it's important to have that discussion with every patient. And then for the C2 and the C3 patterns of catamenial epilepsy, you have to suppress the pre-ovulatory estradiol surge. Currently, the only way to do that is to basically suppress the entire menstrual cycle with GnRH analogs, with the gonadotropin releasing hormones, which suppress your whole menstrual cycle and can benefit seizures. There's several different forms, like you have oral contraceptive pills, like the combination pills. We have depot injections. You have to be mindful if you're using pills and their interactions with seizure medications. Like some of the seizure medications can decrease the efficacy of these pills, and then some of the pills can decrease the efficacy of the seizure medications. And then again, all counseling in terms of, long term, you're suppressing your estrogen, progesterone, your surge, which can again lead to endometrial cancer, osteoporosis. So again, sort of weighing out the risk versus benefits in these patients is extremely important. I'm sorry, I'm not sure why I keep having trouble forwarding the slides, but hopefully it doesn't take up too much time. Some of the other nuances with catamenial epilepsy, there is compelling evidence from several papers that show that women with catamenial epilepsy show a pretty substantial reduction in seizures during pregnancy, much more than women with epilepsy that don't have a catamenial pattern. This generally is sort of like attributed to the absence of these, cyclical hormonal variations and increase in the circulating progesterone levels during pregnancy. And women with catamenial epilepsy also tend to see they experience an exacerbation of seizures in the years leading up to menopause, but they experience a reduction in seizures after menopause. And again, sort of, the thought process here is that you don't have these estradiol surges with, the ovulatory cycles. And in the late menstrual period, when menses stops and the hormonal production of the estradiol stops, they start seeing an improvement of seizures. So it's a lot of hormonal variations that results in these changes. Okay. And sexual dysfunction, there's a lot of sexual dysfunctions that can be associated in, women with epilepsy. One very common condition is polycystic ovarian syndrome, PCOS. It's twice as common in women with epilepsy compared to general population. And possible explanations for this are very similar, like the seizure activity in the brain that alters your hormonal production, Hypothalamus regulates the pituitary, which in turn controls ovarian hormonal production. So patients who have left or right temporal epilepsy, for example, patients who have left temporal epilepsy, they have more of these gonadotropin releasing hormone pulses than normal population or normal controls. And women with right temporal lobe epilepsy have fewer gonadotropin releasing pulses. So when you increase your gonadotropin release, that induces the pituitary to secrete more of the luteinizing hormone and less of the follicle stimulating hormone. So when you have less of the follicle stimulating hormone, your ovarian follicles fail to mature and they don't ovulate and they start accumulating in the ovaries as these small ovarian cysts, leading up to what we call as a polycystic ovarian disease, or polycystic ovarian syndrome, where when the follicle doesn't mature, it doesn't make the aromatase, and so they land up, converting the estradiol, and it's secreted as testosterone, and that's when you have all of these hyperandrogenic symptoms. So this is like the simplest, sort of breakdown of definition of polycystic ovarian disease or polycystic ovarian syndrome. And there's also several studies that correlate that there's a higher Depakote has been it's shown a higher association with polycystic ovarian syndrome. It promotes insulin resistance and weight gain and possibly hyperandrogenism. It also increases the testosterone secretion. It basically blocks the conversion of testosterone to estradiol in women who take this medication, and it affects folliculate process in animals, and we think that it probably does the same in humans as well. And there are more anovulatory cycles in women who take Depakote. And again, as everybody knows, that it's also the most teratogenic of all seizure medications. So it contributes to more harm in women than we like for it to do. Sexual dysfunction is also pretty common in women with epilepsy. Higher incidence of, there's just decreased desire or potency, and some of the other factors that can contribute to this are role of your seizure medications, perceived stigma, there is mood, self-esteem. So again, having this discussion in clinic and addressing all these issues like social factors, hormones, and not just seizure medications, talking about patients' social well-being, dynamics of a couple and family, exploring all of this is extremely important. And it's also important to remember that sexual dysfunction may not always be related to epilepsy, and you have to make every effort to rule out other medical, urological, or gynecological conditions. For example, you have vaginal dryness. Testosterone and aromatase inhibitors can increase your testosterone level and decrease seizures, and also sort of improve the mood and sexual functions. But it needs further studies in this group. Contraception, there's several different forms. There's progesterone only, where you have pills, the implants, and the depots, and the IUDs. Then you have the combination of estrogen and progesterone pills, or dermal patches, or they come as vaginal rings. There's non-hormonal contraceptions, where you have the condoms, the diaphragms, IUDs. Again, important thing to remember when you're counseling or talking about this with women in epilepsy is that some of the seizure medications can affect estrogen and progesterone levels, reducing the efficacy of the birth control. And sometimes the birth control can also reduce lamotrigine levels, some seizure medication levels. Okay, some seizure medication levels. So it's again very important to sort of be mindful of these, interactions, and then be mindful of counseling them. Like for instance, if someone's using combination pills with Lamictal, you want to make sure you tell them that you have, counsel on an extra additional mode of contraception. Like, maybe you also use IUDs in terms of this, and periodically checking for seizure medication levels to.
አይ ገና ዶክተር ገብቶ ነው ስለሚያነበው ይቆያል።
And just sort of making sure that you're also periodically checking levels to make sure that the seizure medication levels are in therapeutic range. Okay, so fertility and pregnancy is a huge topic, and like I said, each one of this can sort of be made into a presentation in itself. And I apologize for, I'm not sure where this thing is showing up on my screen, but hopefully it's not interfering too much of what you can see on your screen. So the typical question that we always come across is, do women with epilepsy have fewer children? Is fertility sort of affected? The answer is no. Epilepsy has similar prevalence in females, and approximately 1.3 million people are of gestational capacity, meaning they all have the ability to get pregnant. Seizures are quite rare. I mean, it is a complication, and it is the most common of all neurological condition. It affects less than 1% of all pregnancies. So while it's a rare complication, it is still a complication. And over 90% of pregnancies in patients with epilepsy are generally safe, with some low risks of complications, and with safety and guide with being aware of the risks and appropriate safety guidance. It's are always important to sort of discuss with your neurologist, and therefore people with epilepsy can get pregnant and have safe and healthy pregnancies. Okay, and in general, we recommend taking 400 micrograms of folic acid even prior to pregnancy, like if you are pregnancy planning and throughout the course of the pregnancy. There's a lot of studies that support that this helps with the development of the nervous system for the fetus, and it also is sort of like neuroprotective from patients. There's also been studies that have shown that independent of seizure medications, when you do supplement with folic acid, women with epilepsy or the children born to women with epilepsy have lower risk of autism, and they've known to have higher IQ in these patients. So that's why we do all of this counseling in any women with childbearing age group, in the age group of 16 and 57 years. And the general recommendations are before you get pregnant, we would like for your seizures to be relatively well controlled. So you talk about consolidating seizure medications and having at least a good 1 to 2 years of seizure freedom. And also, more importantly, to have planned pregnancies, and then talk about how we sort of monitor the levels and the course of pregnancy. There are some really good prospective studies that have followed women with epilepsy compared to women without epilepsy. And so okay. Can you still hear me? I just got a notification saying that I'm muted.
Yeah, we can
Okay.
hear you. We can hear
Okay,
you.
perfect. Okay. So this basically the study that said, they followed women who came off their contraception and were trying to get pregnant. So essentially, they followed women with epilepsy and women without epilepsy, and they found that both groups of patients, that is, women with epilepsy and without epilepsy, have a very comparable likelihood of achieving pregnancy when they compare it to the healthy control study population. And the same group also looked at how seizures change during pregnancy. It was the same study. So you can see that a majority of the times, 50% of the times, there is no change of seizures during pregnancy. In fact, the EURAP study, which is the European Pregnancy Registry, 66% of the patients who were enrolled in the study had remained seizure-free during pregnancy. But you can, it is expected that pregnant people with epilepsy will have no difference in seizure rates during pregnancy. But the more important things to remember is that the seizure freedom period for 9 months prior to pregnancy was more likely to be indicative of a positive change, or more likely to predict that you will continue to remain seizure free during pregnancy. So that's why it's extremely important to have this conversation during pregnancy planning and ensure that you have at least a 9 to 12 months period of seizure control with the least combination of medications, preferably with monotherapy and folic acid supplementation. And all of those are essentially positive predictors that your seizure frequency will not change during pregnancy. Some of the other things that can happen during pregnancy, and again, important part of counseling, is that metabolism changes, there are volume changes, seizure medication levels tend to drop. From the same study, which is the same paper that I was talking about, you can see that pregnant women had a 74% chance of having a change to their seizure medication levels compared to controls, where the majority of women did not have a change to your seizure medication levels. So again, this is why it's very important to talk about having a pre-pregnancy baseline level for your seizure medications. And it's important to test these levels in every trimester and making sure that they don't drop to more than 50 to 60% as the pregnancy advances. And these are things we as providers can do to make sure that patients are not at a higher risk of, having seizure recurrence during pregnancy. The slide is a bit complicated, but I think it sort of, highlights the complex relationship that we between pregnancy and epilepsy and its treatment. So these are all of the things that you're thinking about as a neurologist when someone's planning pregnancy. So with seizure medications, you're looking at side effects, you're looking at following their levels, and you're looking at ensuring they have sustained therapeutic levels during pregnancy. And you're also thinking about potential fetal complications, right? You want to make sure that they don't have as much teratogenic exposure, reducing the rate of congenital fetal malformations. For the mom, we're thinking about whether she's going to be at a high risk of preeclampsias, high risk of postpartum hemorrhage, or if there's going to be the need for cesarean section, C-section during at the end of pregnancy, and other things like impact on potential seizures, that how seizures can affect the mom and the baby. It can cause maternal and fetal hypoxia. It can cause fetal heart rate decelerations, particularly convulsive seizures, and potentially also result in miscarriages. Non-convulsive seizures can and has reportedly been known to cause trauma or ruptured fetal membranes and increase the risk of infections, premature labors, and things like that. So a lot of these things are sort of interrelated. So it's not just yes, take folic acid, check your seizure medication levels. I think there's a lot of things that you need to be thinking about as you're helping your patients throughout their pregnancy journey. Seizure medications, again, there's a few. We want to limit unnecessary exposure. This is important to sort of mitigate the risk to fetal development and teratogenicity. There is need for more data on some of the newer anti-seizure medications, but the rate of congenital malformations is certainly, it has been an established risk with some of the older ones. That you can see here, the highest risk are Depakote or valproic acid, phenobarbital, and the lowest risk is with lamotrigine and Keppra and oxcarbazepine. Again, as I said, alluded to earlier, polytherapy is a dose-dependent risk, and ideally, if you're able to keep them at monotherapy, it's ideal. With newer medications, I think a lot of the studies are constantly evolving. I think we're, seeing somewhat of a relatively modest positive data with medications like lacosamide or Vimpat, but the rate is still somewhere between 1 to 2% of major congenital malformations, even with the newer medications. This again, just to show you the rates in general. The risk of major congenital malformations is anywhere between 2 to 3%, even in general population. So a majority of our what is considered to be relatively safer seizure medications is no different in women with epilepsy compared to general population. So oxcarb, levetiracetam, lamotrigine still sort of fall under the acceptable risk, or the risk that is pretty comparable to general population. And as you go on with some of these older medications, the risk of major congenital malformations obviously increases, the worst being with Depakote, and topiramate and phenobarbital. So we obviously want to stay away from these medications, or transition to some of the newer medications, if the soonest as possible, and not like during pregnancy. Ideally, you don't want to make change when you already have a patient who's coming to you while pregnant. This graph, and hopefully it projects reasonably well on your screen, it points to basically, again, sort of like supporting the fact that there is a dose dependent increase, or a dose dependent proportionate increase in congenital malformations of these patients. Highest with Depakote, again. If you're using Depakote beyond 500 milligrams in pregnancy, it is known to have a higher risk of having congenital malformations. Even with lamotrigine, as you can see here, if it's less than 325 milligrams, it's relatively in the safer, but if it's more than 325, there is still sort of like an acceptable increase in the rate of congenital malformations. Similarly, with carbamazepine, if you're going beyond 700 milligrams, there is a higher risk of congenital malformations. And the most common ones in the descending order are particularly heart, muscle, skeletal, facial. The most common ones that we encounter in clinical practice are like atrial septal defect, ventricular septal defect, tetralogy of Fallot, higher rates of hernia, this cleft lip, spina bifida. And exposure in the first trimester generally has the greatest risk, and we talked about how dose dependent with Depakote is significantly higher risk in these patients. And also polytherapy, like if you have a combination of several of these medication, also puts people at a higher risk of congenital malformations. Okay, and 90% of the pregnancies, despite all of this, can result in normal deliveries without any complications. However, it's not without risk. Epilepsy is considered to be a high risk. And women with epilepsy usually see high risk maternal fetal medicine. And again, seizure control before your pregnancy is very important to ensure that you can have a relatively low risk throughout pregnancy. I talked a little bit about how some of the complications that mothers can encounter. One is preeclampsia, where you have fluid retention and proteinuria. There is increased risk of hemorrhage, abnormal bleeding before or during pregnancy. There's higher rates of complication, again seen in patients who have Depakote, who are been taking Depakote throughout their pregnancy. It's not to say that I actually carried two patients who had primary generalized epilepsy, and the only medication that they were responsive to was Depakote. So despite having them on a combination of like Keppra or lamotrigine, their seizures were extremely uncontrolled. They had both convulsive and myoclonic seizures, and we needed to have that sprinkle, like, a very low dose of 500 milligrams of Depakote, essentially to keep them from seizing during pregnancy. Um, in fact, one of my patients was having at least 30 seizures a day, and the only thing that would slow it down to about 1 to 2 seizures a month was having a low dose of Depakote. So I think, again, sort of like individualizing this and making sure that you have a regimen that's tailored to each of your pregnant patients is very important, and counseling them about the risk and benefits, like, with the data that you have, is also extremely important, so they can make that informed decision. There's a higher rate of both elective and emergency C-section in pregnant patients with epilepsy. Epilepsy by itself does not necessitate the need for a C-section unless there's another medical condition that will predispose them to a higher risk for the need of C-section. Seizures are pretty rare during the time of delivery. Less than 2% of pregnant patients with epilepsy will have a seizure during labor. We encourage them to sleep, take naps, if able, to prevent sleep deprivation as much as they can. And seizures during delivery can actually be treated. So again, it's important to sort of have a plan with your OB and your neurologist in terms of what to expect and how to tailor your seizure medication doses, even at the time of delivery and postpartum. We get a lot of questions about breastfeeding, like new moms asking, is it safe to breastfeed their newborn babies while they're taking seizure medications? We all know that breastfeeding provides benefit to both mother and children. And the amount of seizure medications, in theory, children, the newborns are already exposed to seizure medication levels when it crosses the placenta. So in utero, they already have some exposure to seizure medication levels. But when you look at the serum concentrations of seizure, for some of these medications, particularly like the older ones like Depakote, carbamazepine, phenobarb, and phenytoin, they are not thought to penetrate into breast milk at clinically significant levels. And while some of the medications, like some of the newer ones like the Keppra and lamotrigine, they penetrate into breast milk in potentially clinical amounts. So this box plot actually shows infant to mother concentrations, and you can see it's pretty low for medications like carbazepine, carbamazepine, somewhat a little bit on the higher range or variable range for lamotrigine and Keppra. And there is some fluctuations with it, but then again, we always counsel on benefits of breastfeeding outweighing the risks, and this is also something that needs to be individualized and tailored to every mom during counseling. Postpartum safety, we focus on sleep deprivation, generally recommend mothers also having some sort of alternative help, trying to encourage them and, putting some mechanisms in play that will avoid missed medications, like using pill box or phone alarms, and making sure they have like safety precautions in place, like, to encourage them to take showers and not bathe. Keep the bathroom doors unlocked, turn down hot water temperatures, have them change the baby on the low ground, and make sure they have some sort of a padded surface underneath while they're feeding the baby, and avoid co-sleeping. Postpartum mood disorder, very common in women with epilepsy. the comorbid mood conditions is seen in more than 40% of patients with women in epilepsy. They have a higher susceptibility in the postpartum period. Depression risk is anywhere between 13 to 20%. And it's usually, again, very prominent in the first few weeks of pregnancy. Some of the things that can make depression worse is that if you have polytherapy, if they have a high seizure frequency before and during pregnancy, if they have a pre-existing disorder, of a history of a mood disorder, or if you have unplanned pregnancy, these are all thought to worsen or have an increased susceptibility of causing postpartum mood changes in women with epilepsy. Okay, so that's about pregnancy. And then a quick word about infertility. Again, there's a few studies that epilepsy will not interfere with treatment of infertility, that IVF is recommended and safe. But the most important thing is to sort of making sure that you discuss medications that, can potentially have interactions with treatment therapy. For example, IVF has really high doses of estrogen, and estrogen can decrease your lamotrigine levels, so making sure that that's being monitored and treated for and counseled throughout the course of therapy is extremely important. And sometimes you may need to increase the dose of their standing seizure medications to sort of prevent breakthrough seizures if someone's undergoing artificial reproductive therapy. Okay, and then we'll move on to menopause and hormone replacement. You know, menopause and perimenopause is much more common, or premature menopause is much more common in women with epilepsy compared to general population. On an average, menopause was known to happen 3 years earlier in patients in women with epilepsy compared with women who do not. Perimenopause is the time in a woman's life where the menstrual cycle is sort of shifting from regular cycles towards permanent infertility. And then you can have very erratic hormonal fluctuations during this time. So estrogen levels can be very high during this perimenopausal period, and some women can experience worse seizures at this time. And this is basically thought to be because of these high estrogen levels. And once a woman enters menopause, your hormonal levels, become low, and then your estrogen levels sort of stabilize. And women with epilepsy will start noticing a decrease in their seizure frequencies in the postmenopausal period. And, if you remember, we talked about how this pattern was most frequently noted in women who have a history of catamenial epilepsy, and that a subset of women with epilepsy are especially sensitive to these hormonal changes. So if you do have a history of catamenial epilepsy, this is a trend that you can expect in those patients where seizures sort of worsen in the perimenopausal period and they sort of get better in the postmenopausal period. So again, it's helpful for knowing this trend and sort of helpful in counseling. So you can also adjust your seizure medications and hormone replacement therapies during this time. Which sort of leads us into the next slide. Hormone replacement therapy. This is usually consistent with estrogen in combination with sort of synthetic progestins. There's a lot of studies that was looked at it. Essentially, one of the studies was designed as a questionnaire to determine whether adding hormone replacement therapy to medication regimen in postmenopausal women was associated with an increase in seizure frequency. And the results of the study found that there was an increase in seizures during menopause, and that dose-related increase in seizure frequency was noted with hormone replacement therapy. So I generally don't recommend hormone replacement therapy in postmenopausal women, and I tell them that if your postmenopausal symptoms are really bad, they can talk to gyne about potential symptomatic treatment. And if they absolutely need to go on hormone replacement therapy, I counsel on the risk of breakthrough seizures that can potentially happen with this. I've had 3 or 4 patients who were very well controlled with seizure freedom between 10 and 11 years. And with rare breakthrough seizures, but the moment they went on hormone replacement therapy, landed up having breakthrough seizures within 1 to 2 days of it. There was another study actually that was prematurely terminated because the hormone replacement therapy was associated with breast cancer, and then they could not actually complete the study. So it's not just the risk of worsening seizures, but it's also the risk of other sort of complications that can come with it. There are studies that have looked at these the synthetic progesterones, to see if they could be safer rather than having like the combination of estrogen and progesterone. And they were trying to see if like some of the natural progesterone metabolites like allopregnanolone could help reduce seizure frequencies, but none of these studies are like in huge numbers, and there needs a lot more validation and more studies to sort of help support that. All right, a quick word on male patients. Men and men and testosterone. Like testosterone can also, like estrogen, have dual and opposing effects on seizure threshold, at least theoretically. Testosterone, as you can see here, it's broken down. It can get broken down by the aromatase into estrogen or the estradiol, or it can be converted to what is called as a dihydrotestosterone, which is like the allopregnanolone, which is a more progesterone sort of a metabolite. So most of the same effects that you see with women also apply to men. Low testosterone levels in men with epilepsy can affect energy, mood, sexual function, bone density, and seizure control. And with regards to fertility, there's a lot of studies that have suggested that men with epilepsy also have lower fertility rates and lower number of offsprings. There's a 40% reported low birth rate in in men with epilepsy compared to men without epilepsy. And apart from that, there's also a lot of changes with seizure medications. Patients on Depakote have a higher risk of sexual dysfunction. Medications like carbamazepine, phenytoin, oxcarb, even Keppra, levetiracetam can affect the testosterone levels. While lamotrigine, we don't see as much hormonal changes, and most of the studies seem reasonably favorable to lamotrigine. Apart from just affecting like sperm function, they've also been known to be associated with lower sperm count, dysmorphic sperm forms, or like sperm motility, and which has not been shown in studies that have been looked at with lamotrigine. So it seems to have a relatively favorable profile compared to some of the other seizure medications. Okay, and then talking about testosterone supplements, these again, if you remember the previous slide, that when the testosterone gets broken down into the progesterone metabolite, and giving testosterone supplements is actually markedly improved sexual function dysfunction in men. It improves the energy, the drive, and the mood, and it is also known to reduce seizure frequency by about 40%. Since this is a couple of randomized control trials, I've listed one at the bottom of the page. There is no data with regards to fetal malformation as much, and there's no increased, there is no data to support there's an increased risk of prematurity or newborn weight or birth defects or cognitive development or impairment in the offsprings of men who have a history of epilepsy. Okay, so this is kind of, coming down to our last slide where we can see that hormones play a very important role in seizures, both men and women and transgender patients with epilepsy. Increasing levels of estrogen tends to increase seizures, with higher levels of progesterone tend to reduce seizures. Hormonal fluctuations can exacerbate seizures at particular points in life. We've seen how that it can impact patients during the time of their periods, like catamenial epilepsy, during menses, during pregnancy, also in the perimenopausal period, and they present a very uniquely challenging aspect to treatment. And treatments are tailored and um, treatments are tailored and relatively specific for hormone triggered seizures, and they appear to be effective, as we know from some of the trials. And clinicians can prescribe treatment, but it's very important to sort of tailor it and individualize it to every patient. And very important in counseling and planning at every session as you follow these patients, no matter when you're seeing them. If you're seeing them as a teenager, if you're seeing them as a young adult, or if you're seeing them during pregnancy or their menopausal period, I think knowing the data and counseling them is extremely important, and it can guide them through this very complicated course of their lives, and sort of make things easier for them, and also allows them to sort of making informed decisions when you have this data and having this discussion together. So that's the end of my talk. I'm happy to take any questions over the next 5 minutes, or I'm happy to also just give you my email if you want to reach out to me directly. Let me see here.
Thank you so much. Really appreciate your presentation, and I'm sure everyone has found it very useful. There are questions already on the chat, so if you could kindly answer them. I think we have 3, the
Okay.
last I checked.
One second, I'm having trouble getting back to the right screen. Let me see here. Stop share. Okay, there we go. I think I back on. Okay, let's see here. First question. Would you recommend switching from lamotrigine to another anti-seizure medication, such as Depakote, for a woman who is recently delivered and is breastfeeding? No. So we generally don't recommend transitioning once a woman, once a woman is already established with pregnancy and is already sort of carrying this. Like I said, if you remember the slide that talks about the infant to maternal infant serum concentrations of seizure medication in breast milk, it's actually very, very less. Majority of the times we don't even screen for these serum concentrations in the breast milk. Some women who are taking phenobarbital, when they stop feeding, there are sometimes you can notice like withdrawal symptoms in the baby, like they're somewhat sort of lethargic or have like irritability. In those patients, we could sort of supplement with a low dose of benzos and things like that, but we generally don't recommend switching over. And someone who's already like pregnant or delivered and breastfeeding, we advise not to change any treatment during that time. The next question is, what do we do if woman with epilepsy comes to us after being pregnant and taking teratogenic drugs? What do you recommend on dosage after and before pregnancy? Again, if someone comes to you, and 90% of the times in the real world setting, that's what happens. You counsel them for like 5 years of their lives about pregnancy and planned pregnancy, and then one fine day they show up in your clinic and they're like, surprise, I'm pregnant. And it's very common. It's very commonly encountered in practice. I've had two patients who we were trying to transition from zonisamide and Depakote before pregnancy, but landed up coming to the office, becoming pregnant on those medications. And by the time you realize you're pregnant, you're already sort of like 4 into 6 weeks of pregnancy, where the neural development has sort of already taken place. So the best thing you can do at that point is hope that they've already been taking folic acid or multivites, to reduce the risk of neurodevelopmental defects at that time. Again, we don't change. We essentially transition. Like, I've had patients who've come to me on zonisamide and Depakote, and we've counseled about the risks of it, and then sort of taken them through pregnancy. The dosing recommendations are based on, you want to target them for your pre-pregnancy level. So if you have a pre-pregnancy level, as you know that the seizure hormonal changes like estrogen, progesterone surge in pregnancy can drop your seizure medication levels as they go from first to the second to the third trimester. So essentially, you're checking levels periodically. I typically tend to check like once every 2 months in the first trimester. I'm sorry, once every 3 months in the first trimester, once every two in the second trimester, and more frequently in the third trimester. And make sure that you are aiming for your pre-pregnancy dose. So the dosing essentially is based on that. And once they get to about 35 or 36 weeks, and unless they are high risk for prematurity or preterm labor, I outline a plan to make sure that the seizure medications will drop, or give them a dosing titration to reduce the seizure medications by 25% after they've delivered. Ideally, I take my time because, again, patients are, women at a high risk of sleep deprivation, stress. There's a lot of changes that happen after giving birth to a baby. So I don't want to drop them dramatically in the first week, but over the first 7 to 10 days, I make sure I try to bring them down to the same level that they were before pregnancy. Otherwise, they're going to get very toxic on seizure medications. And if you do it too soon, too quick, like if you drop the medication right away, like let's say you have a patient who was on lamotrigine, had 600 milligrams during pregnancy, but the pre-pregnancy dose was 150 twice a day, like 300 a day. If you drop it too soon, too quick, you are at a risk of putting them at a risk for breakthrough seizures even after delivery. So you want to be mindful and counsel them, and do it as like a slow tapered process, and have that discussion as you go through each trimester. Given that safer anti-seizure medications for women of childbearing age are often unavailable or too expensive in Ethiopia, how can we adapt treatment and support strategies to protect mom and child while ensuring seizure control? That's a great question. I don't know if I'm going to be able to answer that um, uh, in a true manner. I think we just get so used to the availability of these medications here. We just assume that everybody needs to be on these safer ones. Unfortunately, in without access to some of these medications, and non-compliance is also a huge risk in even in patients who have access to some of these medications. Like, they just women just decide to stop taking their seizure medications because they don't want to affect the babies, right? So even if they do have access to lamotrigine and Keppra, it can get challenging. I think the best strategy is to make sure that you can counsel them pre-pregnancy and ensure that they have at least 1 to 2 years of seizure freedom on their current medications, and talk about keeping the lowest therapeutic dose of the medication throughout pregnancy. I don't know, if you don't have the ability to transition them to some of the newer ones, or some of the reasonably safe ones during pregnancy. I think you want to minimize the risks of polytherapy in those patients. You want to minimize the risk of going up on, beyond extended like beyond 600 or 1600 milligrams of Depakote that can put them at a high risk of congenital malformations. But whenever possible, again, if you're able to doing it, I think all of these changes need to be done pre-pregnancy and not during pregnancy. We say folic acid decreases autism when you're comparing with general population, or epileptic mothers have a higher rates of having autistic children and folic acid. That's a great question, and I would point you to the MONEAD trial. It's MONEAD trial. So the trial actually followed patients, women with epilepsy who were on Depakote and some of these other medications, and they looked at the rate of autism in children, particularly with women with epilepsy. They didn't compare this with general population. So women who actually took folic acid supplementation had a higher improved IQ and reduced risk of autism than women who did not take folic acid during the pregnancy. Folic acid right now is a pretty hot and controversial topic here as well. So I don't recommend more than 400 micrograms of folic acid. I tell them, your regular multivites, whatever you get in there. Some practices will recommend at least 1 milligram of folic acid, and some practices have also recommended at least 4 milligrams of folic acid if you're taking some of the older seizure medications like carbamazepine and Depakote and things like that. There's been a lot of recent literature, and if you look at American Association of Epilepsy, a lot of the topics is surrounded with this, like the controversy regarding higher folic acid, and there's been an increased risk of blood cancers in patients taking higher folic acid. I think the data is still sort of evolving, so I generally recommend just taking 400 micrograms of folic acid in all my patients. And I don't think I've had, except for maybe one or two patients, I don't think I've had anybody on like Depakote. Most of the times they're a combination of something else or just like monotherapy with something else. Happy to drop my email. Next question is, women with epilepsy is already on Depakote. When should we have to discontinue the drug before she gets pregnant? Ideally, yes. Like I said, you want to, all of the changes you want to make it before pregnancy, and you want to make sure you have at least a good 6 to 9 months period of stability on a new medication before they can get pregnant, because it's important to have that accurate pre-pregnancy baseline level, which will guide you throughout the course of the pregnancy. How should clinicians handle postpartum care regarding breastfeeding, sleep deprivation, seizure triggers? I think the extent of clinician involvement is mostly just with counseling. I encourage some of my pregnant patients to come with family during the last trimester visit. So not just telling the patients what they need to do. I encourage the families to be more involved. Like I have them bring their moms, I have them bring their partners, and tell them that, the risk for a mom is high when you're going to be sleep deprived. There's going to be stress. She's going to be feeding. There's a lot of changes that are happening, and they need to be extremely supportive, particularly when you're sort of bathing or like feeding. I tell them to have like one-on-one assist in the first few weeks or the first few months of pregnancy. Breastfeeding, again, we talked about how you can counsel on breastfeeding risks, and each has to be tailored to every woman. Like there are some women who choose not to breastfeed, and that's a personal decision. And for women who actually do breastfeed, you can counsel about the risks of, how minimal the serum concentration of seizure medications are in breastfeeding. And sleep deprivation, unfortunately, I don't know if there's a quick fix strategy for this. The old saying goes like sleep when the baby sleeps. In reality, it's never that easy. So I think as much as you can outsource, if you have the ability to outsource, I encourage a lot of my moms to do that. Recommended interventions for sexual dysfunction. Again, I think it's a lot of counseling between the neurologist and the OBGYN. We've talked about a few things. I think the one thing is to make sure that the sexual dysfunction is not a consequence of epilepsy itself, not related to seizure medications, because in that case, you can do something to like help, switch over or talk about like different forms of like seizure medications, but you also want to make sure that they don't have a primary gynecological disorder like vaginal dryness or like painful libido and things like that, which can be addressed or like which actually can be treated from a gynecological perspective. Vitamin D supplementation recommended taking older seizure medications, not particularly in women like during pregnancy. I tell if someone's on Depakote or carbamazepine and Oxcarb, in theory, I tell my patients to take vitamin D supplementations. In general, what you need is about 500 to 1,000 international units, which you get, with the regular multivites that we typically get over the counter here. And I also check for vitamin D levels, like if their levels are like below 20 or 25, I tell them to take higher vitamin D supplementations. And we also periodically check for bone scans. We do a DEXA scan in patients. If someone's been on Depakote or carbamazepine or phenobarb or phenytoin for more than 2 years, I typically tend to do a bone scan. If the scan is normal, I will screen every 5 years. If the scan is abnormal, then I will screen every 2 years. And if the numbers sort of start declining, like if your bone numbers are declining or your percentage risk of osteoporosis or osteopenia or bone fracture, they can predict your 10-year fracture risk. If that sort of declines with every scan, then that's an indication that you should be talking about, switching over or talking about some of the safer, newer alternative seizure medications.